Hello.
Hey, Connie.
Hey, Joe. How you doing?
Pretty good.
Yeah?
Lung cancer. I mean, come on. At the time I was 44 and just absolutely shocked. And my oncologist, Dr. Temel, has been fantastic in thinking about Jim Windhorst as the person and saying, when I was first diagnosed, by the next spring, we want you feeling like Jim Windhorst of old as much as possible. And she accomplished that.
A lot of traditional medicine, and even within oncology, we tend to focus on just treating patients with therapy like chemotherapy and radiation. But I think equally important is how patients and their families live with their cancer diagnosis. Traditionally, palliative care teams were not asked to see patients until they were very ill, even in the last days or weeks of their life. But there's sort of a novel way of thinking about the involvement of the palliative care team, trying to get them involved earlier in the course of their disease. So one of the main emphasis of my research is to try to study novel ways to have palliative and oncology care work together.
So they're having a tough time managing his pain, is that right? And palliative care is a subspecialty of medicine. It's a team of clinicians, usually comprised of doctors, nurses, social workers, and chaplains, who care for patients who have serious illness. And our focus is really to help patients improve quality of life and to live as fully as they can. It's common that people confuse hospice and palliative care, and these are actually two separate services. Palliative care is a service that's available to any patient independent of prognosis, while hospice is a medical benefit that's available to patients who have a prognosis of 6 months or less.
I know it gets really stressful for you when you have to think about scans, and it's really helpful for us to know them when it's not a crisis. Otherwise, you're getting people to meet you when the bad things start happening, because the difference for us is we don't hold a key to their treatment. So patients sometimes will put on their best behavior for their treating team, and then we can ask the very same questions in the few minutes afterward, and they'll be more honest with us about how things are going because we don't have the key to treatment.
So the first thing that I said to her, I don't want to talk about how do you feel. How do you think I feel? And it's more, how do you deal with it? So Connie will tell you 5 different things that could be useful and lays them out in front of you. And you as the patient have to choose which is comfortable for you, whether it's bad news, whether it's communicating with your kids, whether it's just starting to live full-time at home and working with your wife and establishing boundaries around the house.
I really feel that my job is to help people do as well as they can, to live as fully as they can, and I feel partnered with patients in that I have the time to actually get to know them and their families in a very deep way.
When you have a diagnosis like cancer or heart failure or kidney failure, you're not going to feel normal. Things aren't going to go back to the way you were before you had a cancer diagnosis, so things will be different. But trying to maximize as well as a patient can feel, trying to manage their symptoms, manage the side effects of chemotherapy, the side effects of medication.
Patients who received palliative care at the time of diagnosis and were followed over the course of their illness had improved quality of life, less depression, and remarkably, they lived 2.5 months longer. And that was really new information, that this would be possible to actually integrate this care and that we'd have these really important findings.
And palliative care was very helpful in getting me to the point where I needed to primarily focus on my health. I don't know how people did it without it in the past. I would say you can't do it without it.